going to receive our master class by the ICP members forum of API West Bengal branch. Now I request Dr. Apurva Mukherjee, who is one of our course director, to introduce today's chairperson and also the subject. Apurva Mukherjee.
Thank you, Dean Sir, Professor Amol Banerjee, and thanks to all my participants, beloved colleagues and beloved students who have joined in this master class. My task is to introduce one of the course directors, Professor S.B. Ganguly, who is a doyen in the field of medicine, who has served as Professor of Medicine from Calcutta Medical College. After retirement from the government service, he became the professor and head of Department of Medicine at KPC Medical College, Yadavpur, and he has a very prolific academic career, who is immensely interested in rheumatology. Of late, he is a renowned figure in the field of rheumatology all over the country. With this, let me introduce the topic as well, and our most beloved academician, Dr. Sanjay Bandyopadhyay, is going to take up this topic. But the topic is highly important for all the postgraduate trainees all over the state, and I sincerely hope that all will be benefited most from this master class. Approach to ascites, a case-based approach. Ascites is one of the very common clinical signs encountered in the day-to-day practice by all caregivers. It is an accumulation of free fluid in the peritoneal cavity, and it is not only contributed by various gastrointestinal illness, but so many other illnesses associated with accumulation of free fluid in the ascites, and thereby the presentation of different clinical signs along with a very significant sign of free fluid accumulation in peritoneal cavity, otherwise called ascites, makes a very interesting scenario in various clinical situations. With these few words, I request our chairperson to proceed with this master class. Professor S.B. Ganguly, please.
Thank you, my bosom friend Apurva. Now, let me take the pleasure of introducing Sanjay Bandyopadhyay. Sanjay Bandyopadhyay is a very known academician. He passed MBBS from National Medical College, then he passed MD from Calcutta University, then DM from the same. He has a brilliant academic career and a very known speaker. He was secretary and scientific chairman of API West Bengal. This subject, as it is already introduced, is very common in our clinical practice and also very important for the PGT in exam. In every MD exam, there are 1 and 2 cases. There must be 1 and 2 cases of ascites. Causes are many, and some are difficult to find cause, some are difficult to treat. So I hand over the mic to my younger brother, Sanjay Banerjee. I think he will amaze us with his interesting cases and finding. Over to you, Sanjay.
Thank you, sir. First of all, my acknowledgement to API and West Bengal branch of ICP for giving me this opportunity. My respect to Professor Amol Banerjee, Professor Mukherjee, Professor Ganguly, Professor Patel, and all other senior members and my colleagues who have joined today. Back. Now, this is a 25 years old. The case is a 25 years old unmarried female who had a type 1 diabetes and was on irregular medicine. With a history of low-grade fever for 3 months, this lady presented with progressive swelling of abdomen, that is ascites, for 1 month. Accompanying this ascites, she had a steady weight loss, pain abdomen, vomiting after meal, and marked anorexia. A paracentesis was attempted somewhere outside, but that was unyielding. So this is a case of a 25 years old diabetic lady who presented with fever and ascites with significant weight loss. Now coming to the third case, this is an elderly lady of 65 years who is obese, diabetic, and hypertensive. She had a long history of irritable bowel syndrome or functional bowel disease. Now she had presented with rapidly accumulating massive ascites, accompanying pedal edema, and of late developed shortness of breath. There was no history of jaundice, no history of fever, no past history of significance. And at times, she complained of severe back pain, particularly at night. So I have presented 3 different cases of ascites. And from clinical presentation, I think it's quite apparent that these cases perhaps have different etiologies. An alcoholic male developing ascites in the 40s with history of jaundice and altered sensorium and fever. A young lady, diabetic, undernourished, presenting with weight loss and fever with ascites of 3 months duration, and an elderly lady presenting with rapidly accumulating ascites. I think all these have different connotations and different etiology. So worldwide, cirrhosis of liver or chronic liver disease is the commonest cause of ascites, and to be followed second by malignancy. 10% of all ascites unclassified are related to malignancy. In India, however, tuberculosis is an important cause of ascites and is responsible in some cities to up to 10 to 15%. There are other rare causes of ascites. Some people with cardiac disease might present as ascites, and in some cases of fulminant liver failure or acute pancreatitis, there can be ascites. Let us come to the first case. This is an alcoholic with jaundice, GI bleeding, ascites, altered sensorium, either encephalopathy, maybe hepatic encephalopathy or metabolic encephalopathy, and with fever at admission. So jaundice in an alcoholic can occur due to acute alcoholic intoxication called Zeev syndrome with accompanying hypertriglyceridemia. It can occur with acute alcoholic hepatitis. But once this patient develops ascites, perhaps we are dealing with a case of chronic liver disease. Similarly, GI bleed in an alcoholic can be because of malodorous tear where there is a preceding retching without nausea, maybe due to peptic ulcer disease because its incidence is increased in alcoholic. But in a GI bleed with a background jaundice and subsequent development of ascites is very suggestive of chronic liver disease. Similarly, ascites in an alcoholic is predominantly due to chronic liver disease. Alcohol does increase the risk of malignancy of particularly upper GI tract, including pancreas, liver, and stomach and esophagus. Some alcoholic might suffer from cardiac disease like alcoholic cardiomyopathy, or because of tuberculosis, they may have tubercular peritonitis or an effusive constrictive peritonitis. So if we combine and see all of these and take them together, the only possibility in this patient whom we are dealing and this patient who goes on developing encephalopathy and fever is a case of chronic liver disease or cirrhosis of liver. Now, the history taking in patient of cirrhosis of liver is very important, particularly if the patient is alcoholic. We need to quantify the amount of alcohol intake because this amount has different connotations in males and females, and the duration of alcohol intake because 10 to 15 years of regular alcohol intake is necessary to develop significant amount of liver damage. And whether this ascites diminished or resolved intermittently in addition to abstinence from alcohol, thereby suggesting a direct link with alcohol intake. However, even if the patient is alcoholic and has an alcoholic liver disease, risk factors for viral hepatitis, particularly hepatitis B or hepatitis C, or because of acute decompensation, a travel history, or history of diarrhea for hepatitis A or E are also important. Some of the chronic liver diseases might run in family, like hemochromatosis, or in our country, Wilson's disease. The rapidity of accumulation also gives an idea about the underlying liver disease, whether this is an acute decompensation or it is a slowly developing ascites or it's a portal vein thrombosis superimposed on a stable compensated chronic liver disease. However, in any patient of alcoholic liver disease with ascites, as I already mentioned, a symptom suggestive of malignancy should be ruled out, including prior history of cancer, associated significant abdominal pain, and history of even in patient of long-standing cirrhosis, a possibility of hepatocellular carcinoma, which results in ascites should also be considered. Again, as I already mentioned, the alcoholics are prone to certain cardiac diseases like cardiomyopathy that can cause congestive cardiac failure, chronic passive congestion of liver, and in the long run, cardiac cirrhosis. There may be effusive constrictive pericarditis, which occurs because of tuberculosis in patients who are immune suppressed from their chronic alcohol intake. In any alcoholic admitted with ascites or presenting with ascites, the possibility of infection like spontaneous bacterial peritonitis, tuberculosis, or HIV infection should also be considered. Now, what is the natural course or prognosis of ascites in alcoholic liver disease? Any alcoholic liver disease, even if the patient is compensated and doing his routine work, 60% of patients will ultimately develop ascites within a period of 10 years. And once ascites develops, the median survival is 5 years. And in case of refractory ascites that does not respond to diuretics, the median survival is very dismal. It does not exceed 6 months. So once ascites develops, the disease usually has a very downhill course. Median survival of ascites is 5 years, and median survival of refractory ascites is 6 months. But are all ascites bad? There are certain pointers which will suggest which cirrhotic ascites is bad. If a patient is having cirrhotic ascites with a persistently low sodium, persistently low mean arterial pressure, higher creatinine, lower urinary sodium excretion, or lower ascitic fluid total fluid concentration, because that is responsible for opsonic activity of ascitic fluid. So if all these parameters, or most of these parameters are present, or if the patient presented with ascites with spontaneous bacterial peritonitis, that is a bad ascites, because most of these people don't live beyond 1 year since their presentation. And how does ascites happens is there are previously many theories like underfilling or overfilling theories, but recently the mostly accepted theory is a theory of systemic vasodilatation because of production of nitric oxide. This vasodilatation leads to a decrease in effective arterial blood volume, so that renin-angiotensin sympathetic nervous system or aldosterone system is stimulated. So they retain water, they retain sodium, as a result there is ascites. If this goes on unabated, there is renal hypoperfusion and development of hepatorenal syndrome. So systemic vasodilatation because of liberation of nitric oxide, because this nitric oxide and other substances which are perhaps generated in response to endotoxemia. This endotoxemia reaches the systemic circulation because liver cannot work, and portosystemic shunting of the blood takes away these endotoxins from the gut directly into the systemic circulation. So what is the relation between the portal hypertension, varicose bleeding, and ascites, and what is the chronological relation? Every case of chronic liver disease passes through a stage of compensated cirrhosis, then decompensated, and finally further decompensated stages if they are followed for a significant period of time. In compensated stage, they are usually asymptomatic because patient may or may not have varices. However, in decompensated stage, they present with variceal hemorrhage, ascites, encephalopathy, and jaundice. So in a significant number of patients, before the appearance of ascites, varices or other features of portal hypertension will usually develop. And we now know that in compensated cirrhosis, hepatic venous pressure gradient is usually less than 10. And in decompensated stage, particularly variceal hemorrhage and ascites, the hepatic venous pressure gradient is usually more than 10. And this has importance because the difference between the mortality between compensated and decompensated cirrhosis is significant. The annual mortality rate is up to 3% in compensated liver disease, whereas it reaches on an average 30 to 50% in patients of decompensated cirrhosis. So how to diagnose this compensated cirrhosis is very important, because once decompensation occurs, prognosis is universally poor, and most of the therapies are now directed to retard or delay this decompensation in patients of compensated cirrhosis. History and examination will give some clue. However, there are other biomarkers, there are other measurements, endoscopic procedures, radiology, and all other things will, in combination, will help to identify a case of compensated cirrhosis. So the ultrasonography may show an altered liver morphology with splenomegaly collaterals and shunt, whereas the Doppler study might show an increased portal vein diameter with hepatofugal flow and reduced or absent respiratory variation. If we can measure the hepatic venous pressure gradient, the clinically significant portal hypertension, as I already mentioned, is diagnosed when HBPG is more than 10 millimeter mercury. The endoscopy might show esophageal or gastric varices, and fibroscan, that is transient elastography, will show a value of more than 25 kilopascal. So any value on transient elastography more than 25 kilopascal, any appearance of esophageal or gastric varices on endoscopy, and hepatofugal flow with a dilated portal vein diameter with absence or reduced respiratory variations are important investigatory findings to support a diagnosis of compensated cirrhosis. And once compensated, this patient, and take the example of our patient, in the first stage patient had a GI bleed, so he bled from varices. Then the patient develops ascites. So that is first non-bleeding decompensation. Then the patient developed hepatic encephalopathy. So the second non-decompensated complications. And then the patient developed infection, that is perhaps spontaneous bacterial peritonitis or other infection that presented with fever. So the presentation of our patient typically fits with the natural course and progression of portal hypertension, variceal bleed, decompensation, further decompensation, and late decompensation in a patient of cirrhosis. Now, ascites is defined by International Ascites Club as grade 1, which is detectable only by grade 2, which is detectable grade 3, which is large and gross ascites. So as a general rule, grade 1 ascites is an ultrasound finding. 50 milliliter of fluid is sufficient to be picked up by CT scan, 120 milliliter sufficient by ultrasound, 250 to 500 milliliter by clinical examination, 500 for fluid thrill, 2 liters, 500 for shifting dullness, 2 liters for fluid thrill, and that fluid must be under tension. So any grade 3 ascites is similar to what we pick up by fluid thrill, and grade 2 ascites is what we pick up by shifting dullness. And in a patient of ascites, the initial evaluation should start with the examination of the ascitic fluid rather than examination of blood or liver function test, because it is of paramount importance to rule out infection. Most of the 15% of the patient, maybe 20-27, ascitic fluids are infected without symptoms, and 80% of the patient initially presenting with ascites might have an underlying cirrhosis. Coagulopathy, however, is not a contraindication for paracentesis. So with an increased INR value, the paracentesis administration of fresh frozen plasma is not required. 22 gauge needle, withdraw 25 to 30 ml. We have to avoid scar, to avoid bowel loops. Midline paracentesis has fewer complications. Usually left side is favored because right side there may be hepatomegaly. So we need to send ascitic fluid for cell count, differential, and albumin estimation, as well as bedside inoculation in the culture bottle, at least 2 culture bottles at the bedside. The laboratory tests which are helpful in evaluating a patient of ascites as necessity are cell count, culture to rule out spontaneous bacterial peritonitis, albumin along with serum albumin to identify whether this is a high SAG ascites or low SAG ascites. Other optional tests could be protein, LDH, glucose, amylase, gram stain, depending on the suspected cause or probable differentials, as well as the simultaneous estimation of LDH, glucose, and amylase in the blood. Some of the tests which are TB culture smear, bilirubin or cytology are rarely used and are used to rule out either tubercular peritonitis, biliary complications, or malignant ascites, respectively. Now, most important aspect of evaluation of ascitic fluid report is classification of ascites into serum ascitic albumin gradient. Because if it is a high SAG ascites, where difference between the serum albumin and ascitic albumin is more than 1.1 gram DL, is suggestive of portal hypertension with a sensitivity of 96% and specificity of 92%. And cirrhosis is the commonest cause of portal hypertension, and there are other causes like extensive liver metastasis, portal vein thrombosis, acute Bardet syndrome, or maybe the veno-occlusive diseases. Whereas low gradient ascites is usually suggestive of infection, inflammation, or malignancy. Myxedema or hypothyroidism has a peculiar tendency to present either as a high SAG, transudative, or a low SAG, that is exudative ascites. Now, how to manage ascites? Patient with cirrhosis and fat presentation of moderate ascites, because patient with mild ascites which is picked up by ultrasonography does not need any therapy. This is as per International Ascites Club. However, patient with moderate ascites which is grade 2 and picked up by examination of fluid thrill, so examination of shifting dullness, the usual recommendation is to restrict salt intake to 5 to 6 grams, that is make up to 88 to 90 millimole per day. And after salt restriction, we need to commence this patient on diuretics, the loop diuretics and the potassium sparing diuretics, because hyperaldosteronemia is an important accompaniment of any chronic liver disease. So our first choice is to start with spironolactone at a dose of 100 milligram, increasing every week or every 7 days by 100 milligram to a maximum dose of 400 milligram per day. And if the response is inadequate, that is with this amount of diuretics, potassium sparing diuretics, patient must have sufficient weight loss, that should be more than 2 kg per week. But if the weight loss is less than 2 kg per week and ascites is not responding even up to 400 milligram per day of spironolactone, then we need to add furosemide 40 milligram, increasing every third day to 160 milligram maximum. However, the recent trend is in favor of giving a combination of spironolactone and furosemide, because spironolactone will cause a rise in potassium that could be tackled by furosemide, which will cause a fall in the potassium. However, the bad part of this combination is that furosemide usually does not work if you give beyond 80 milligram. But in combination, if you increase the spironolactone, you have to concomitantly increase the furosemide because it's a fixed dose combination. So diuretic response is defined by 1 kg weight loss per day. This is very important. And 0.5 kg weight loss if there is no edema, or 1 kg per day weight loss if there is edema. So the response should be prompt and response should be maximum. With the suboptimal response, we have to check for the compliance with the salt intake, and for that we can do a spot urine sodium by potassium ratio. If spot urine sodium is low, so the patient is having enough of diuretics, we need to add other diuretics or other method. If sodium excretion is very high, more than normal, so perhaps the patient is not compliant on salt restriction. He or she is taking excess of salt, which is not coming to the attention of his family members. However, with increment of diuretics, invariably will come the side effects related to diuretics. We have to monitor for the diuretic side effects, and we might need to discontinue diuretics if the sodium is less than 125. There is worsening hypo or hyperkalemia. If there is hepatic encephalopathy, diuretic needs to be stopped completely, at least for 48 hours. And if there are electrolyte imbalance-induced muscle cramps. However, if there is resolution of ascites before these side effects appear, we have to continue this patient on the diuretic dose to the lowest possible, and preferably with spironolactone alone. There are ascites which call refractory. So what is refractory ascites? Refractory ascites constitutes two groups. One is diuretic resistant ascites, where you cannot do anything giving even the highest dose of diuretic. Another is diuretic intractable ascites, where you cannot give maximum dose of diuretics because of side effects or complications. So both this diuretic resistant, which is not working with the highest dose of diuretic, and diuretic intractable, where you cannot give the highest dose of diuretic, both together constitute refractory ascites. And to call a patient as refractory ascites, we need to identify that we have given enough of diuretics for at least 1 week, that is 400 milligrams spironolactone or furosemide 160, and the patient is on a salt-restricted diet of less than 2 to 6 grams per day. And lack of response when there is less than 0.8 kg over 4 days. Diuretic-induced complications are well known, and these are there are specific criteria when called what is diuretic-induced encephalopathy, hypokalemia, hyponatremia, or hyperkalemia. So to know why the diuretic, whether diuretic is working or not, and whether we need to change the diuretic or add in a second line treatment or counsel the patient with dietary sodium, simultaneous measurement of daily sodium intake and particularly daily urinary excretion is important. As I already told, if the daily sodium intake and daily urinary excretion is equal, so there is no increase, we are happy with the diuretics. If the daily sodium intake is low, but still patient is not excreting any sodium, so diuretics are not working, we have to consider other treatment like LBP or TIPS, large volume paracentesis or transjugular intrahepatic portosystemic shunt. And if the patient is excreting excess of sodium, so where this sodium is coming from? Definitely it is coming from diet. So patient is not compliant on diet. So patient need to be counseled with the dietitian regarding strict dietary sodium restriction. So any ascites, whether it is moderate or severe, hydrothorax, accompanying hyponatremia, or with ascites with HRS. Now there are two categories, HRS-AKI and HRS-CKD, that is HRS type 2. All the ascites are sufficient indication for refractory transplantation. So once a patient of compensated cirrhosis develops decompensation in the form of ascites, whatever might be the, and it's clinically detectable ascites, whatever might be the initial response to diuretics, the patients are fit to be considered for liver transplantation. This is more true if the ascites is accompanied with hydrothorax, hyponatremia, or hepatorenal syndrome. But do you have any drug other than diuretics and transplantation, both of which lie at two distant ends? Recently, there are drugs in our therapeutic armamentarium which can help to mobilize ascites in patients who are not responding to diuretics or have a side effect with diuretics, and even whom we cannot include in the liver transplantation list because of technical feasibilities or non-availability of donors. The first and foremost is albumin. I think albumin is now coming more and more in hepatology domain from the domain of nephrology. Continuous weekly albumin infusion, even on OPD basis, decreases the chance of repeat hospital admission, duration of stay in admission, other complications, mortality, as well as they give favorable response to diuretics. So this is becoming almost a norm all over the world, particularly in the Europe, to give these patients of decompensated cirrhosis with ascites weekly albumin on OPD basis, at least 2 units of albumin, because normally available 100 cc of 1 unit of albumin contains 20 grams. So 40 grams of albumin weekly or twice weekly. And they could be maintained for 24, or maybe now there are reports they could be maintained for 5-6 years on this albumin without any significant deterioration in their clinical status. Another drug is midodrine, which is alpha-1 receptor agonist, which is sympathetic agonist. They give better control of ascites if given along with diuretics, particularly diuretic-induced hypotension, which is quite common with furosemide or torsemide, can be corrected by midodrine. However, they don't give any survival benefit. And midodrine, because they are alpha agonists, so they cannot be combined with carvedilol given for control of portal hypertension, because that is alpha 1 antagonist. Third drug in this group is tolvaptan, which is available as a sodium nitrite and other drugs, in dose between 15 to 30 milligram. And there are study on different populations has shown lack of efficacy in ascites management and prevention of recurrence. So they are mostly used for treating hyponatremia, not for ascites. So two wonder drugs, two new kid in the block are albumin and midodrine. Albumin intravenous weekly doses for a prolonged period, and midodrine for 1 to 3 months gives important adjunct therapy in the management of ascites between two polar ends of diuretics on one end and liver transplantation on the other end. Albumin also gives significant survival advantage and benefit in patients who develop post-paracentesis circulatory dysfunction. The therapy of refractory ascites is, however, either large volume paracentesis tips or alpha pump. Alpha pump is a low volume, self-regulated, implantable pump, which is laparoscopically placed behind the skin, and this pump has a two cannula. One is to ascitic fluid, and another is on the roof of the urinary bladder. And this is regulated. This is a low flow system, so it drains fluid continuously into the infant bladder. Once the urinary bladder gets full, so the drainage system stops and the patient voids, and again the drainage system starts. This is very useful, but there are many complications, and this system initially came in European countries, is now out of favor. What options are left with managing refractory ascites are large volume paracentesis and tips. Large volume paracentesis gives symptomatic relief. However, we have to give concomitant albumin, otherwise there will be post-paracentesis circulatory dysfunction that increases mortality and hepatic encephalopathy. On the other hand, tips, it corrects portal hypertension, improves hemodynamics, and has an advantage over large volume paracentesis. But with tips, with more and more portosystemic bypass circulation, there are higher chances of hepatic encephalopathy. So what is left for controlling moderate ascites is diuretics, may be supplemented by midodrine, and what is left for refractory ascites is large volume paracentesis with albumin, with or without midodrine, or maybe long-term albumin administration. Now, coming to the topic of ascitic fluid infection, spontaneous bacterial peritonitis, because our patient presented with fever, which was documented in the emergency. So the commonest cause of fever in an ascitic patient is infection. And the commonest site of infection in an ascitic patient is ascitic fluid infection, called spontaneous bacterial peritonitis. And there is recent expansion in the nomenclature of SBP, or spontaneous bacterial peritonitis, or infection of the ascitic fluid, because the SBP, by standard definition, the ascitic fluid must show PMN, polymorphonuclear count, more than 250 cells, and it should show a positive culture. However, cultures are often difficult, not obtained for at least 72 hours, giving rise to significant deterrent in the management of patients with SBP. So the worldwide, the International Ascites Club became more lenient, more flexible to the concept that finding a finding of more than 250 polymorphonuclear leukocyte in the per cubic millimeter of ascitic fluid is sufficient, even with the negative culture, and called culture negative neutrocytic ascites, because they have a similar prognosis of that of classic SBP, and they should be treated in the similar line to that of spontaneous bacterial peritonitis. On the other hand, person whose polymorphonuclear counts are low, but still have a positive culture, they have a bacteria inside the ascitic fluid, so they should be treated along the same line like SBP. So the classic SBP, the classic findings may not be apparent in some of the cases. So the guidelines are rather flexible to incorporate patient, whether they have higher polymorphs, whether they have positive culture, or whether they have both. All should be considered to be spontaneous bacterial peritonitis. All should be treated in the line of spontaneous bacterial peritonitis. Now, the prognosis of nosocomial SBP is perhaps worse than healthcare-associated SBP, because nosocomial SBP develops for admission, and there are high risk of multi-drug resistant SBP. And the best way to prevent recurrent SBP is to give the non-absorbable oral antibiotics. Now, this is an interesting observation in JAMA in 2009, and I must share this with some of our learned senior colleagues, that though shifting dullness is the characteristic feature, this is often asked in the examination for students, what is the characteristic feature of ascites? It is free fluid, that is shifting dullness. However, see, in a clinical setting, to diagnose ascites, the shifting dullness has an odds ratio of only 2.1, whereas the fluid thrill has an odds ratio of 5.3, thereby suggesting that presence of fluid thrill is very, very suggestive of ascites, notwithstanding the possibility of a huge ovarian tumor, huge ovarian cystic tumor that may also cause fluid wave. And this is an evidence-based explanation of this in JAMA 2009 in Rational Clinical Examination Supplementary Issue. Now, during paracentesis, all ascitic fluid needs to be inoculated into the culture bottle, as I already said, and antibiotic should be started empirically because 15% asymptomatic patient with ascites and 70% of patient of ascites with fever will have ultimately SBP. So it is better to start empirical antibiotic pending the investigation reports. However, PMN counts reports are usually available, and in patients who have a bloody ascites, we may subtract PMN 1 for every 250 RBCs, and this is a very beautiful calculation. This was reported 4 decades back. But once this, whether this diagnosis is achieved or not, the empirical treatment should start with the 3rd generation cephalosporin, either cefotaxime or ceftriaxone, or maybe in recent years, because of cephalosporin resistance with levofloxacin, or in cases when you suspect the extended spectrum beta-lactamase, Enterobacteriaceae, meropenem, or daptomycin. In every case of SBP, concomitant albumin administration is suggested, but that is not as albumin once daily per day. The standard or the schedule accepted dose is 1.5 gram per kg on day 1. That is a loading dose within 6 hours of SBP diagnosis, and then 1 gram per kg on day 3. So, and this is an approval in certain case randomized control trial in New England Journal of Medicine. And the patient once recovers from the SBP with the treatment of antibiotic in conjunction with albumin, they should be placed on secondary prophylaxis lifelong or till transplantation. How adjunctive measures in SBP are also important. There are certain support of in the favor of oral branch chain amino acid that can improve nutrition and ultimately improve outcome. And even a patient who has ascites and is on the waiting list, once develops an episode of SBP, their position is upgraded. They are placed higher on the list, waiting list, once they have an episode of SBP. PPI therapy for long increases the risk of SBP. So a patient of ascites developing SBP, PPI should be discontinued, vitamin deficiency should be corrected, and patient of ascites developing SBP, if they continue taking beta blocker, that will cause more harm than benefit. So once SBP, beta blocker also needs to be stopped, which the patient is already receiving for portal hypertension management. Now, there are unique challenges of ascites management in India, because in India, we have higher incidence of cirrhotic. I think there are many senior cardiologists in this group. We have higher incidence of cirrhotic cardiomyopathy, and Asian population usually are poor beta blocker tolerable. And we have lower serum creatinine because of lower muscle mass and higher incidence of sarcopenia. Similarly, we have poor diuretic tolerability because of hot, humid climate and higher sweating. So we have higher incidence of post-paracentesis-induced circulatory dysfunction. There is universally lack of access to healthcare facilities till date to a significant number of our population. There are low muscle mass, so higher prevalence of hepatic encephalopathy because ammonia cannot be converted into other metabolites inside the muscle. And this patient also does have poor tips for tolerability because after tips, hepatic encephalopathy is almost universal. But first and foremost of these hurdles is that there is higher incidence of tuberculosis in our country that can present as tubercular peritonitis or ascites, and that gives rise to diagnostic dilemma even for an astute clinician. Thus, we come towards the possibility how to differentiate tubercular ascites from portal hypertension-related ascites. Constitutional symptoms will support tuberculosis, as also diuretic intolerance, that is, patient developing recurrent AKI without any removal of the ascitic fluid will suggest tuberculosis-related ascites. Portal hypertension ascites, at least in the initial stage, will have a sufficient response to diuretics. Similarly, in ascites, abdominal imaging of portal hypertension will show features of chronic liver disease. However, in tuberculosis, that by taking abdominal cocoon enlargement of lymph nodes with normal liver or at the most an mild hepatosplenomegaly of tuberculosis. Ascitic fluid is classically high sag in portal hypertension, whereas it's classically low sag in tuberculosis-related ascites, and there are other biochemical markers or other molecular markers in ascitic fluid that will suggest a possibility of tuberculosis, though their sensitivity varies across the spectrum. Gastroscopy in portal hypertension will show some telltale evidence of portal hypertension like various portal hypertension gastropathy. That takes us to our second case, which was a 25-year-old unmarried female, which I left 10 slides back, who has diabetes and undernourished with a history of fever for 3 months, progressive swelling of abdomen, that is ascites for 1 month. And because we know the 85% of all cases of ascites, so we might miss if we consider each and every case of ascites due to chronic liver disease. She is diabetic, undernourished, thus predisposed to infection, which is quite common in our country. The patient complained of weight loss in spite of developing ascites or accumulating fluid. The patient has marked anorexia, and the paracentesis was unyielding because there was not much of fluid, or perhaps there was significant addition inside the abdomen that impairs paracentesis. So what are the clinical and laboratory features of tubercular peritonitis? Nearly 60% of all tubercular peritonitis presents with fever and 60% present with weight loss. Abdominal pain is the predominant symptom of abdominal peritoneal tuberculosis, and 20% may present with diarrhea because of concomitant intestinal involvement. The abdominal tenderness is found in less than 50% of the cases, and classical doughy abdomen, doughy feel of the abdomen is found in classically, as mentioned in textbook, is only 10% of the cases. But ascites is demonstrable in 73% of the cases, and there may be an abdominal mass for 6 to 40% of cases. An interesting finding in many studies is that abdominal tuberculosis and Crohn's disease, when they present with intestinal stricture, the tuberculosis is more commonly present with abdominal mass than Crohn's disease. Palpating an abdominal mass in Crohn's disease is distinctly rare. Getting an abdominal mass in a patient with suspected TB versus Crohn's or TB versus malignancy is more in favor of tuberculosis. This is because of involvement of the adjacent omentum, mesentery, and the surrounding lymph nodes. The PPT MAN2 is positive in 38% cases, abnormal chest radiographs in lower percentage of cases. Then ascitic protein is usually high with a lymphocyte predominance. ADA, there are widely varying ranges of ADA positivity and sensitivity in patients of tuberculosis. Tubercular peritonitis, AFB smear is only 3%, culture is only 30%, and interferon gamma is in a significant number of patients, they are positive. Now, what is the diagnostic yield of different modalities which are now came in the our day-to-day practice in evaluating peritoneal tuberculosis or tubercular peritonitis? ADA, if that varies on the cutoff, because worldwide the cutoff of ADA in ascitic fluid is less than 30. However, the ICMR recommendation for tubercular peritonitis is more than 39. So if a ADA is more than 30, I'm sorry, this should be more than 30. ADA is more than 30, it has a sensitivity of 96% and a positive predictive value again of 95%. Tuberculin skin test, that again varies whether you use 5 TU, 10 TU, or 15 TU, and in which population, whether they are BCG vaccinated or not, you are testing this test. Because with 5 TU in a population which have not previously received tuberculin skin BCG vaccination, the sensitivity could be as low as 38%. Interferon gamma release assay, and there are two tests, T-spot and QFTGT, of which T-spot is usually preferred because it gives an early diagnosis, rapid diagnosis. So interferon gamma release assay had a sensitivity which is much higher than MAN2 test, but lower than ADA test. So, but it has a very high specificity and it has a very high positive predictive value. So by and large, amongst all these tests, ascitic fluid ADA, ascitic fluid adenosine deaminase level of more than 30 or maybe more than 33 has perhaps the best values in almost all of the parameters like sensitivity, specificity, positive predictive value, and negative predictive value. However, IGRA is a close second for that. Tuberculin skin test has gone out of favor for identifying at least active tuberculosis. However, IGRA and TST, that is immunointerferon gamma release assay and MAN2 test, that is tuberculin skin test, they are very useful to identifying latent tuberculosis. And presently, actually, their value is identifying latent tuberculosis when you are going to place a patient on immunosuppressant or on monoclonal antibodies. Now, what is the value then of gene expert? Because this is one of the common questions asked in the examination for postgraduate student and a dilemma faced by the physician. Is gene expert the ultimate messiah of diagnostic dilemma? No. Even gene expert, there are two studies. This is one study in just last year and another in 2016 showing the sensitivity of gene expert is 28 and 27. That is 27 to 28%. And if it is gene expert for multi-drug tuberculosis rifampicin assay, the sensitivity is as low as only 17%. So sensitivity of gene expert is very low in fluid. Maybe it's high in sputum, maybe high in tissue, but it's very, very low in ascitic fluid. So for ascitic fluid, we usually prefer ADA and IGRA, that is interferon gamma release assay. We usually don't prefer this gene expert assay in the ascitic fluid. Now, laparoscopy is the diagnostic procedure of choice. So, any case of suspected tubercular peritonitis, diagnosis is by histology, by inspection, and biopsy. Only on inspection, when there are extensive nodules on the peritoneal surface, as shown in this figure, the sensitivity is 93%, and if that is combined with biopsy of representative lesions, the diagnosis is 98%. Another important issue is that you can simultaneously take a liver biopsy to rule out underlying significant cirrhosis. From India, we have a Bhargava classification of tubercular peritonitis, like dry form, wet ascitic form, and stricturing fibrotic form. And there are risk of doing laparoscopy, however, in fixed peritonitis form, because there may be risk of perforation of the gut. Complications occurs in laparoscopy, and there are rare reports of mortality with laparoscopy. So any patient of suspected peritoneal tuberculosis, if you have got a confirmatory histology on laparoscopy, it's anti-tuberculous therapy, but that is often not available. So in a patient with low SAG ascites, if ADA is above 30 and you have a positive IGRA, then start anti-tuberculous treatment. And this is one of the international guidelines says. Again, in a patient of low SAG ascites, if you have a high ADA with a positive culture in the ascitic fluid, then start anti-tuberculous treatment. Similarly, if any patient of low SAG ascites with high ADA and gene amplification positive, means if it is positive by gene expert, though the sensitivity of individual cases is low, if you combine these parameters like low SAG ascites, high ADA with positive IGRA, low SAG, high ADA, positive culture, low SAG, high ADA, gene amplification, then you can start anti-tuberculous treatment. However, all these values of AGA, gene amplification is not that useful in patients of chronic liver disease, because then the body's response is different. I think in that case, one only option we left is a gene amplification assay that will only show, give a positive diagnosis, and we can start anti-tuberculous treatment. No liver disease, 2 into 4 plus 4 into 2. Liver disease with no liver disease, HIV on intratracheal, same therapy of 2 into 4 plus 4 into 2. HIV not on antiretroviral, 2 into 4, then 7 into 2. But the liver disease is present, there are several options. We can omit pyrazinamide, or we can omit INH altogether, or we can give a fluoroquinolone, cyclosporin, particularly streptomycin, particularly if the patient develops deterioration in the liver function while getting anti-tubercular therapy. However, an important cause of differential diagnosis again on tuberculosis is malignancy. Worldwide, malignancy is more common than tuberculosis. Thus, we come our final case of 65-year-old lady, which is obese, diabetic, and hypertensive with a long history of IBS, and now presenting with massive ascites. Logically, IBS will not cause ascites, so she has developed something new, which is rapid accumulation and massive ascites with pedal edema. But there was no jaundice or no fever. The patient complained of severe back pain, as I already mentioned, which was more at night. So malignant ascites is defined by National Cancer Institute as a condition in which fluid containing cancer cells collects inside the abdomen. And there are many mechanisms. Either it could be due to peritoneal deposit of the carcinomatous cell, or it may cause secondarily due to local biologic effect of tumors or vena cava compression. But unless you get a fluid containing cancer cells or appendicitis, you cannot term it as, or maybe cell block, you cannot term it as malignant ascites. And our patient who underwent CT scan and showed a solid cystic mass of 8 cm in right ovary with peritoneal deposits, omental cakes, huge ascites, and right-sided pleural effusion. So the ovarian mass and the value of CA125 came to be very high, and the ascitic fluid was also positive for malignant cell, as also the pleural fluid. So finally, we dealt with a case of ascites in an elderly lady who had an ascites because of a complication of chronic liver disease. So this is the clinical data accumulated over maybe last 30-40 years regarding the malignant ascites. Malignant ascites usually presents with abdominal swelling and abdominal pain. There may be systemic symptoms like nausea, anorexia, vomiting, and fatigue. Worldwide, the commonest cause of malignant ascites is ovarian cancer, followed by pancreatic biliary, and then gastric. Colon is much less. I repeat, worldwide commonest cause of malignant ascites is ovarian cancer, followed by pancreatic biliary, then gastric, and colorectal cancers as malignant ascites is perhaps much less because of early presentation of colon cancer and regular screening in Western countries. In patient of malignant ascites with peritoneal involvement, the liver is involved more, but however, the body is involved in 1 out of 8 cases, and lung is involved in 1 out of 12 cases. Survival of malignant ascites with ovarian tumor is 2 years. Survival of malignant ascites from all other non-ovarian tumor is very low. It's similar just like that of refractory ascites with hepatorenal syndrome. Now, there are some clinical pointers for malignant ascites. In patient of massive hepatic metastasis because of exudation of lymph from the hepatic surface, there may be high SAG. So malignancy may present with high SAG ascites. And ascitic fluid is not bloody as we often conceive. In malignant ascites, it would be bloody. It's bloody only in 20% cases. And low glucose is more common in malignancy than in SBP or COX. The intent of treatment in malignant ascites is, however, palliative. Most has a survival of 3 to 6 months and on an average on 5.7 months. Particularly, it is not ovarian, and if the patient does not undergo debulking surgery for the ovarian tumor. So what options the physicians are left in treating malignant ascites? Diuretics, do they have a role? Might be, because there are many studies, all of which are very old studies. They are more effective when this patient has hepatic metastasis. Repeated paracentesis up to 5 liter along with concurrent volume expansion. There are some early studies showing that repeated paracentesis at least improves quality of life. Permanent drains, Pleurex catheter, which is FDA approved for pleural effusion, can be used, and there are many studies. However, this patient needs prophylactic antibiotic because these drains and catheters are very prone to infection. For peritoneal venous shunt, there are no randomized control trial. Triamcinolone, that is corticosteroid, delays the time for next paracentesis, and this is particularly true for lymphoma with ascites. Octreotide in one RCT in chylous ascites has shown to be beneficial. So to conclude, while it may appear that ascites is a GI-related problem, the pathophysiology affects almost all organ systems in the body and has a very high morbidity and mortality. Ascites is not a benign disorder, as we already think, because median survival once ascites develop in cirrhosis is only 2 years. And median survival once ascites develop in refractory ascites is 6 months. Median survival of tubercular peritonitis depends on the promptness of identification and treatment, and the median survival of malignant ascites is only 5.7 months. So ascites is not a benign disease. If it is a persistent ascites that requires paracentesis, is not a benign disease. And depending on the cause, it can have a mortality at 1 year exceeding 20% if you take or accumulate all the causes of ascites. And to prevent complications and improve the quality of life, we need streamlined protocol for management and separate protocol for management of cirrhotic ascites, for management of tubercular ascites, for management of malignant ascites. Unfortunately, these streamlined protocols are lacking in any of the society guidelines. Aggressive care of this patient is critical if one wants to avoid high mortality. And for most of this treatment, we have significant advances in this research that helps us to a large extent for physicians, for gastroenterologists, for hepatologists to tackle with most of the cases of ascites. Thank you very much for your kind attention.
Thank you, Sanjay, for wonderful presentation. Now will be engaged in question and answer session. Let me see. No open question. Chat. Peritoneal biopsy versus ADA in tuberculosis of abdomen. Sanjay.
What versus ADA? What versus ADA?
Peritoneal biopsy versus ADA.
Oh.
In
No, peritoneal biopsy I already said 90% sensitivity. Peritoneal biopsy versus ADA, very good, but peritoneal biopsy is not feasible. Most of the cases you have to go for laparoscopic peritoneal biopsy, which is technically difficult, has complications, but this is the gold standard. Because biopsy is the gold standard, microbiological culture is the gold standard. If you say caseistic necrosis on biopsy with Langerhans cell, giant cells, and if you can grow the Mycobacterium tuberculosis on culture, that is ideal. But there are technical problems with laparoscopy guided peritoneal biopsy. It is costly, it is invasive, it's full of complications. Sensitivity of peritoneal biopsy is 97%. Sensitivity of ADA is more than 90%. So ADA could be a good point to start with, and depending on other supportive or ancillary evidence, you can build up a diagnosis of tuberculosis of abdomen. And interestingly, worldwide till date, nearly 25 to 30% of patients of tuberculosis, this is the data from WHO, 25 to 30% of patients of tuberculosis worldwide till date, not only peritoneal, all tuberculosis, they receive empirical anti-tubercular therapy.
No way out is a very good proposition. The next is lean probe assay in the diagnosis of tuberculosis. Line probe assay.
Line probe. So line probe assay is also very useful, but somehow line probe assay relies on the mechanism of identifying the DNA of the Mycobacterium tuberculosis. There are specific segments called T-stat 160 segment that is identified. Its sensitivity and positive predictive values is as good as your genetic analysis like Gene Explorer. Maybe a little better.
Now another biological markers like CA125, CA199.
No, this is very useful for malignant ascites because in malignant ascites, you have to search for the primary malignancy either by CT scan of abdomen, chest, PET CT scan, or these biological markers. If biological markers are elevated, then they are more suggestive of malignancy, but they're not very characteristic of malignancy. And if you consider this, measuring this marker, particularly what I am talking about, CA125, and if you consider this marker in blood, then maybe it's suggestive of ovarian malignancy, but other malignancies can cause rise in this. But there are beautiful studies showing that CA125 in ascitic fluid can be raised even in tubercular peritonitis. So that is the main problem of relying too much on this cancer markers of CA125, because tuberculosis can cause a rise in CA125, and there are many reports on that.
So they have a more prognostic value.
And they are more prognostic value, but if you treat them on serial assessment, you can identify whether there is residual or recurrent disease.
Another question: can lacilectone be given in ascites other than CLD?
That I already discussed. In tuberculosis, they have no role. They will increase the kidney injury or hyponatremia. But in malignant ascites, diuretics have definite role. So basically, physicians are left with no option rather than referring malignant ascites to cancer hospitals. And we don't know what is actually happening there. How do they do intraperitoneal chemotherapy or hyperthermic therapy? We don't know. So what little options we physicians have, we can start with diuretics. And there are many studies showing the usefulness of diuretics in malignant ascites. Because in most of the malignant ascites, there is a component of hepatic metastasis or at least blockage in some of the exit or egress channels of the liver. So particularly malignant ascites with hepatic metastasis might respond at least for a short period of time to combination of diuretics. And once you are giving diuretics for ascites, it is better to give a combination of potassium sparing and loop diuretics, unless it responds very well to potassium sparing alone.
So now $1 million question, you have touched it, but still there is a question: how to differentiate between TB intestine and Crohn's disease?
No, I think that is a different, because Crohn's disease does not present with ascites, because that is a different issue. How to differentiate between tuberculosis and Crohn's disease? Crohn's disease does not present with ascites. It's not a feature, though it's a transmural disease, and there may be ascites because of accompanying malnutrition. But intestinal tuberculosis and Crohn's have specific criteria on clinical points, on histological, radiological, endoscopic points. I think that's a separate issue. Crohn's disease is not a cause of ascites.
So here it is not very important.
Yeah, not in today's perspective, it is not important. So I have left that issue.
I agree. Treatment of TB ascites is only ATD. Is there any role of diuretics? You have discussed it.
No, I have discussed there is no role of diuretics. Whether there is any role of steroid, no. RCT has shown, apart from neurotuberculosis, there is no role of steroid in peritoneal tuberculosis or intestinal tuberculosis.
How long does it take to respond to ATD?
Now, clinical response should be by 2 to 4 weeks. So what we usually do, we call these patients of tubercular peritonitis, put on ATT, because we need to check their LFT every 2 weeks. So we check LFT at 2 weeks, we assess for clinical response on 4 weeks and 8 weeks, and they have an imaging study, preferably CT scan, if not possible ultrasound, on 8 weeks. So LFT 2 weeks, clinical 4 and 8 weeks, imaging study, which gave the diagnosis, imaging study repeated at 8 weeks.
So I don't know why there is again this question: how frequently does Crohn's disease present with ascites? Does any single report of ascites with Crohn's disease? I don't know.
No, Crohn's disease can present with ascites, but Crohn's disease, that is not because of the disease process. It can have ascites because of superimposed tuberculosis when the patient are getting steroid for Crohn's, maybe because of associated malnutrition. These are the reasons. Actually, we don't discuss as Crohn's disease in ascites.
Okay, let me see. Is there any other question? No. There is no. Let me see again.
Sanjay, there are a lot of questions in the chat box. I think probably Sotto has missed it. I request you to look at the chat box.
Okay. Yes.
You look at the chat box and answer. There are very important clinical questions at the chat box, right? From
Yes, I got it.
Sanjay, you look at the chat box and answer serially.
One question of Kailash ascites.
Okay,
Yes, there is a question on chylous ascites. Chylous ascites, when you have an elevated triglyceride in the ascites.
There are more questions given by probably Shivendu Ghosh. First question is one patient with ascites, paracentesis and all, and 4 colonoscopy, all these things. You please start from the
Okay, sir.
first chat box question.
One patient with ascites, 5 times paracentesis, 3 upper GI endoscopy, 4 colonoscopy, JVP. So, in a patient of ascites, what our senior teachers told us, always look at JVP. So, if you get JVP in a patient of ascites, basically this is for two purposes. One is to rule out cardiac cause of ascites, and another to, in Bandyopadhyay syndrome, you have to rule out whether the hepatojugular reflux is absent or not when there is IVC obstruction. So, if this patient is JVP is pulsating, perhaps we are too much directed towards the abdomen. We need to look to the heart, including echocardiographic examination and others, to look for a cardiac cause of ascites. Because all other investigations are almost normal, I think. Now, second question is HRS and SBP. I have not discussed this because this would have been too lengthy a presentation. HRS, you can call it as an extension of the concept of ascites, where there is renal hypoperfusion along with this increased renin-angiotensin, aldosterone, and sympathetic stimulation that goes on to develop HRS, hepatorenal syndrome. Now, patient of cirrhosis usually develop hepatorenal syndrome at the rate of 20% per year. So the prevalence is quite high. 1 out of 5 will develop HRS. HRS is 2 types. One is HRS1 and HRS2. Initially, the definition was different. Since 2011, we have a different definition. HRS1 presents as acute kidney injury or AKI, and that usually responds to terlipressin and albumin. HRS2, when there is less than 60 ml of creatinine clearance for more than 3 months without any cause of chronic kidney disease, and that is an usually response as refractory ascites. So HRS1 has a high mortality, median survival is 2 weeks only. So if you treat with terlipressin and albumin, the median survival increases to 4 months without transplantation. HRS2 refractory ascites, median survival is 6 months. You have to treat with large volume paracentesis, tips, etc., etc. There is no specific kidney-directed therapy or no role of terlipressin or albumin in slow onset or type 2 HRS. Next question is SBP. Yes, SBP I have discussed. SBP is an infection of the ascitic fluid. If you don't treat, most of them develop into hepatorenal syndrome type 1 or encephalopathy. If you treat them, even there is 70% chance of recurrence in a year. So once SBP, they should be facilitatedly taken for liver transplantation, or they should be placed on oral prophylaxis with drugs, lifelong or till transplantation, because the chance of recurrence is 70% in a year. So more than 2/3 will have a recurrence of SBP, and more SBP, less is the chance of post-transplant outcome. Finally, to look at JVP in all cases of cirrhosis, this is the age-old dictum that you have to look for JVP in all cases of cirrhosis. We are taught on in the MBBS and early MD years to rule out cardiac causes. And what I said, in case of Bandyopadhyay syndrome, there will be absence of hepatojugular reflux. Analysis of amylase and lipase in ascitic fluid and serum. Any rise in amylase of lipase anywhere in the body in any fluid, you suspect of it's a complication of pancreatitis. In blood in acute pancreatitis, ascites in pancreatic ascites, and pleural fluid in pancreatitis complicated by pleural effusion. However, in some malignancies, particularly pancreatic malignancy, ovarian malignancy, might cause a rise in the amylase and lipase in the ascitic fluid. But so for that, what you need to do, you have to go for both ascitic fluid as well as blood amylase, and this is corroboration between blood and ascitic fluid amylase, or you can correlate this ascitic fluid amylase with increased urinary amylase or with increased urinary lipase excretion. But unfortunately, that test is not available in most of the centers. For all practical purpose, amylase and lipase, we estimate whenever we suspect ascites is a complication of acute pancreatitis or chronic pancreatitis, and then there are either clinical or radiological evidence of pancreatic disease. Acute alcoholic hepatitis and ascites is the next question, and this is a very important question, because what we know commonly is ascites. The development of ascites occurs in a course of chronic liver disease, because ascites is a feature of portal hypertension and hepatocellular dysfunction. So it's a complication of chronic liver disease, or whatever is called cirrhosis. But acute liver disease, can it present with ascites? Acute hepatic insult, when there is blockage of the sinusoids particularly, can cause exudation of lymph from the liver surface and can present with a ascites, which is short duration. Most of the cases of ascites complicating acute liver disease. And what are those acute liver disease? Acute alcoholic hepatitis, acute Bandyopadhyay syndrome, or acute drug-induced toxicity or reactivation of hepatitis B. So these are the 4 diseases of which acute alcoholic hepatitis and acute Bandyopadhyay syndrome. Acute Bandyopadhyay usually occurs in the background of hematological malignancy or prothrombotic state. It does not occur in presence of membranous obstruction of vena cava. So acute alcoholic hepatitis and acute Bandyopadhyay syndrome, though acute disease, can present with ascites. Either the patient die because both these diseases has very high mortality, or if they survive, this ascites usually responds either to nominal therapy or without any therapy, just to salt restriction by 1 to 3 months. So acute alcoholic hepatitis, if the patient survives the ascites, and if the patient is abstinent, the ascites will disappear by most 1 to 3 months. The significance is that this patient has a significant sinusoidal hypertension. So if this patient goes on taking alcohol, though they are more likely to develop liver disease in the short term. Next question is?
Next question here. Bandyopadhyay syndrome
Spontaneous versus iatrogenic SBP. Now, we don't use the term iatrogenic SBP. We use the term monomicrobial bacteriacitis, because iatrogenic SBP means what is meant by this term, though this term is obsolete, is when you puncture the ascitic fluid with a needle and you puncture a gut. So there is common continuation between the ascitic fluid level and the gut, and through this microscopic puncture, the gut bacteria will come in the ascitic fluid. But in that case, what is classically taught is that you will get polymicrobial growth. In SBP, classically, you get a growth of single bacteria that may be common, may be uncommon, may or may not be sensitive to antibiotics. But in iatrogenic SBP is now called polymicrobial bacteriacitis. And surgical peritonitis is called secondary bacterial peritonitis. So iatrogenic SBP is misnomer. Now, peritoneal biopsy versus ATA in tuberculosis, I discussed. Line probe assay, I discussed. Biological markers, I discussed. Chylous ascites. Chylous ascites is an ascites when there is an excess of lymph, there is lymph leaks, and chylous ascites can complicate any case of ascites with portal hypertension. Rupture to the cisterna chyli or thoracic duct is distinctly uncommon, unless with massive abdominal trauma that does not occur. So in some cases of portal hypertension, the lymph may leak, giving rise to chylous ascites when the ascitic fluid has a high triglyceride, or in some cases of malignancy or even lymphoma, when the lymph nodes are blocked. So there is defective drainage of the lymph that can accumulate inside the peritoneal fluid. But for ascites to occur, only leakage of the lymph will not cause this. There must be some concomitant portal hypertension. So in most of the cases of chylous ascites, we get some evidence of portal hypertension, some evidence of involvement of liver, maybe primary, maybe secondary. And chylous ascites is very difficult to treat, because another important point in chylous ascites is concomitant malnutrition. So patients' nutrition need to be taken care of by infusion of several nutrients, ascites, fat-soluble vitamins, proteins, because chyle is very rich in both lipids as well as very rich in proteins. Now, management of chylous ascites is also very difficult, and there are many pumps. What I discussed, alpha pump, there are peritoneal venous shunt, and many mechanisms to control this chylous ascites, because in most of the cases, we don't want this lipid and particularly protein-rich fluid to be drained. We want them to be recirculated inside the body. So many pumps or many shunt procedures for chylous ascites has been invented and have been found to be very useful. Chylous ascites is a common condition found in portal hypertension, lymphoma, and malignancy causing lymph node obstruction. Now, Bandyopadhyay syndrome and CAPS. I don't understand the meaning of CAPS. What is CAPS? Is it too many abbreviations? No? Bandyopadhyay syndrome can present as ascites. Again, chronic Bandyopadhyay syndrome, we can have ascites. That is usually a high protein ascites. High SAG with high protein is quite uncommon in chronic liver disease, because in chronic liver disease, it is a transudative ascites. So SAG is high, but total protein is low, because serum albumin, ascites albumin. So if ascites albumin is a denominator, not the numerator. So in any portal hypertension, SAG is high. No, sir, let me finish. Any
catastrophic Aplas syndrome
and low protein, but in Bandyopadhyay syndrome classically and in cardiac ascites, cardiac causes, we have a high SAG ascites, but it is high protein ascites. Now, hematology and ascites, I am not aware. The acute Bandyopadhyay syndrome, because of thromboembolic disorders or metastatic malignancy, lymphoma, lymphopoietic disorders, or potency, proteinase, antithrombin, etc., can present as acute Bandyopadhyay syndrome and ascites. Lymphoma can present as ascites because of chylous ascites or blockage of the lymph nodes. Other purpose, hematology and ascites, I have no idea about hematology and ascites. I think this is the last question. Dr. Shivendu.
Sanjay, there are some questions also in the question answer box. Sir, can Terlipressin can be used in old with hepatorenal syndrome in a known case of ischemic heart disease. Terlipressin.
Yes, that is the problem because, sir, in patient of ischemic heart disease, we usually don't give terlipressin.
Okay.
We don't give terlipressin. We just treat them with albumin because that is a contraindication. Terlipressin ischemic heart disease.
Yes. It's another question. If the ADA is less than 30, low SAG, no M cells, CT abdomen normal, should we start T by small t for TB?
If ADA is less than 30, low SAG, no M cell, CT abdomen normal, should we start treatment for TB?
Okay.
As an official statement, empirical treatment of ATT is not supported or not suggested. But there are situations when you have to left with no other option. If it is an ascites, how I will approach this case, because perhaps ADA was sent because there was strong suspicion of tuberculosis. It's a low SAG ascites further supporting an possibility of tuberculosis. If there are no M cells and CT abdomen is exclusively normal, only option you are left with is laparoscopy and guided biopsy.
Then
The empirical initiation of ATT is, as a principle, not supported.
yes, okay, that's fine. Management of pancreatic ascites.
The pancreatic ascites management is very difficult because this usually occurs in the background of internal pancreatic fistula. Either the pancreatic duct or a small duct branch has ruptured into the peritoneal cavity, and that fistula, called internal pancreatic fistula, abdominal cavity and pancreatic duct communication, usually maintains the ascites. So it's very difficult to treat. Either you have to drain repeatedly, or you have to do an endoscopic intervention to bridge the gap in the pancreatic duct, or maybe surgical intervention. For medical management, only drug is octreotide, but that has to be given subcutaneously at least for 4 to 6 weeks, along with parenteral nutrition to give rest to the pancreas and to decrease the pancreatic secretion. So pancreatic ascites is difficult. Repeated paracentesis, octreotide, TPN, endoscopic intervention, or surgery.
Then another question, should we go to the highest recommended dose of Lasix in Indian population?
Now, I touched on this point briefly because Lasix 160 milligram, what the Western literature says, is rarely tolerated by our patient. We maximally go up to 80 milligram per day. What we do, because there are many combinations of Lasix and aldactone, like lacilactone, etc., etc. So we usually give a combination, but when we think that we have to increase the spironolactone, we just add it alone. Means we give lacilactone, we give aldactone, and we give them in combination. Because this is usually not tolerated by most of the Indian patients. Up to 80 milligram, I think that is even more. Some of the nephrologists use it, but cardiologists or gastroenterologists hardly use more than 40 milligram or more than 80 milligram.
Okay, there are 4 more questions, but already you have answered those questions, so we should not take up those questions.
He is already tired for
Now,
more than 1 hour.
Now I request Shotto to give your chairman's remark.
So again, I will tell that ascites is a very common problem, both in the ward and both in the exam. Sanjay has done it very efficiently and almost answering all the questions. Now, in the last month, before I determined in KBC, I find one cases of thalassemia presenting with ascites, probably due to portal vein thrombosis, due to hypersplenism, or maybe cirrhosis of the liver due to iron deficiency. But these are very rare. So again, I congratulate Sanjay for speaking more than 1 hour. It's a very difficult task, and I think all the PhD and retired person like us who are listening this must be benefited. Thank you again, Sanjay. Now over to you, Professor Amol Banerjee.
Thank you, sir.
Ananda Bakshi is there? If in absence of Ananda Bakshi, I request Dr. Shivendu Ghosh. Dr. Shivendu Ghosh.
Yes, sir.
You give,
I'm there.
please give vote of thanks.
So thank you very much. Thank you, the chairperson, Dr. Satyabrat Ganguly, speaker, Dr. Sanjay Banerjee, and above all the participants who have already participated. And I have also learned a lot from this discussion. And I think this type of conversation should go on years together so that the postgraduate and even myself can be educated from this type of lectures. With this, may I request Dr. Amol Banerjee, our chairman of API ICP, to conclude the session if he thinks so. Okay. Thank you very much.
Thank you, Shivendu. Thank you, Sanjay and Shotto. We are going to adjourn this master class. Again, we will resume the